Today we're starting in Chapter 7 of your book, Mood Disorders and Suicide. What are mood disorders? According to the DSM-5, the defining feature of a mood disorder is abnormal mood with emotional extremes, intense, persistent, and maladaptive disturbances, and other symptoms or co-occurring disorders. Oftentimes you will see this co-occurring disorders in the presence of a mood disorder. Two key moods that we talk about in this chapter are mania and depression. You may be familiar with bipolar disorder, used to be called manic depressive disorder, but another type of mood disorder is unipolar depressive disorder. In this disorder, the person only experiences the depressive episodes without the full-blown manic episodes. For a diagnosis of bipolar depressive disorder, the client or patient must show both manic and depressive episodes. When we talk about the prevalence of mood disorders, the lifetime prevalence of unipolar depression is nearly 17%. That comes out to a 12-month prevalence rate at about 7%. And mood disorders are about twice as common in women as in men. And the lifetime prevalence for true bipolar disorder is close to 1%. So when people joke, oh, you're so bipolar, because people may be happy and then be sad and then be happy again, that is not truly bipolar disorder. And as you see, the lifetime prevalence, which is usually the highest prevalence for a disorder, is still only near 1% for bipolar disorder. When we talk about unipolar mood disorders, we're describing it as a mild, brief depression. It can be normal. People can adapt to it, or it can be used as an adaptive measure. It includes sadness, hopelessness, and pessimism. And these are common human experiences, as well as the experiences of someone with unipolar mood disorder. There are several types of depression that are not truly diagnosed as mood disorder. Depression is not a mood disorder when it's a normal part of the loss and grieving process. We would expect that someone would go through a period of depression or exhibit the symptoms of depression when they go through a loss. In fact, depression is one of the stages of the grief process. Also, postpartum blues, postpartum depression, that experience that women have after having a baby. It could be immediately after, up to a year or two after, when the hormone levels are still getting kind of evened out, sleep is not what it needs to be, and things. This would not be a diagnosis of a mood disorder. Another thing that we talk about is persistent depressive disorder or dysthymic disorder. This is a mild to moderate version of depression. People can live with dysthymic disorder for a long time. They have some normal moods that pop up in there sometime, but overall, the mild or moderate depression is long term. There's a lifetime prevalence of 2.5 to 6%. Of dysthymic disorder, and because there are intermittent normal moods, people may not recognize it as a true disorder because they do have those episodes of good times. Major depressive disorder. For a diagnosis of major depressive disorder, a person must exhibit more symptoms than are required for dysthymia, and the symptoms are more persistent. If you look at the DSM-5 diagnosis, you'll see that they give us amounts of time that a person must feel depressed without any reduction of symptoms and those types of things. For major depressive disorder, we've got two different categories. We have persistent major depressive disorder. This is where a major depression does not let up for more than 2 years. And then we have seasonal affective disorder. And the acronym for that is SAD. ironically. And this would be recurrent depressive episodes with a pattern. The most common pattern is people who have seasonal affective disorder that hits during the winter time when it's cold, it's more gloomy, not outside as much, it gets dark earlier. And so this can be treated. Some people use special lights that mimic the sun rising. They may have other types of lights that they use to try to kind of trick their body into feeling like it's not so dark outside, or that it is not actually as gloomy as it may actually be. There are people that have seasonal affective disorder that hit at other times of the year, but it seems to be most common during those winter months. Some causal factors in unipolar mood disorders. They're both biological causal factors and psychological causal factors. When we look at the biological factors, of course, we take into consideration heredity. These things can be passed down genetically, altered neurotransmitter activity, and a change in hormones or an imbalance in hormones. When we look at psychological causal factors, we've got four main things that contribute to depression: stressful life events, risk-related vulnerability factors, neuroticism or negative affectivity, and early adversity or parental loss has also been found to contribute to depression. There were several different theories about the causes of depression, and if you look in your textbook, you'll see that Freud had one theory. He described depression as anger turned inward. The behaviorists have another idea about it. And then there's the cognitive model of depression, which goes back to those cognitive distortions, the wrong thinking, and your self-talk. One popular model of depression is Beck's cognitive model. And if you look at this, you'll see that there may be an early experience that triggers the depression. Then this leads to the formation of dysfunctional beliefs. That's the cognitive distortions that we've talked about before. So this person kind of internalizes these beliefs. Then, when a critical incident happens, those beliefs become activated, and that self-talk leads to negative automatic thoughts. When we have those thoughts, we begin to have those symptoms of depression: the behavioral symptoms, the lack of motivation, the affective symptoms, the cognitive symptoms, and the somatic symptoms. And it just becomes a vicious cycle. And so that's why when we use cognitive theory or cognitive therapy, we try to change those negative automatic thoughts so that we are not spiraled into those symptoms of depression when we encounter a critical incident. Several of the psychological causal factors, theories about helplessness, theories about hopelessness, and excessive rumination. People with a personality that are tend to ruminate, go back over the past, I should have, would have, could have, those types of things, have regrets. They tend to be more prone to falling into depression. Bipolar disorders. As I mentioned earlier, bipolar disorders are distinguished from unipolar disorders by the presence of manic or hypomanic symptoms. The unipolar disorder is just the depressive symptoms without any episodes of mania. Cyclothymic disorder, we have cyclical mood swings. Those mood swings are less severe than those of bipolar disorder. If you watched your other video, she drew out kind of the ups and downs, and on the cyclothymic, you never got as high as true mania and you never got as low as true depression. You just kind of cycled there in the middle. These symptoms must be present for at least 2 years, and during that time there's not the presence of severe symptoms or things that would push them into a diagnosis of bipolar disorder. Now we have bipolar 1 disorder and bipolar 2 disorder. And the way to remember to distinguish these is that bipolar 1 disorder, you have at least one manic episode or you have a mixed episode. For bipolar 2 disorder, you have hypomanic episodes, but those are not full-blown manic or mixed episodes. If you have trouble keeping that straight in your head, if you go back and watch the other video that explains bipolar 1 and bipolar 2, she does a really good job of distinguishing between those. When we talk about bipolar disorders 1 and 2, there's a lot of common characteristics, and we see that these occur equally in males and females. The age of onset is usually adolescence or young adulthood, and the average age of onset is 18 to 22 years. When we're looking at making a diagnosis, one thing we look at is the frequency. And when you are looking at bipolar disorder, about 3 times as many days are spent depressed as are spent in the manic or hypomanic stage. Causal factors. Again, we've got a biological causal factors and we've got psychological causal factors. When we look at the biological causal factors, we're looking at heredity. There is a genetic predisposition. We're looking at a imbalance or a lack of production in norepinephrine, serotonin, and dopamine. Or we're possibly looking at abnormalities in the transportation of these ions across the neural membrane. For the psychological causal factors, stressful life events, personality variables, low social support, and pessimistic attributional style. There's also alternative biological treatments, and then of course psychotherapy. When we talk about using medications, the most common used for these disorders are antidepressants, mood stabilizers, antipsychotics, which are used to treat the mood disorder. Now, if someone has a diagnosis of bipolar, lithium is very common to use as a mood stabilizer. Usually with the lithium, it takes several visits with the doctor or the psychiatrist to get the amount just right or the dosage just right, because too much can have adverse effects, and then of course not enough does not help the patient. Some alternative biological treatments, electroconvulsive therapy. This is still used. A lot of times when people hear this, they think about One Flew Over the Cuckoo's Nest, but it has come a long way and is faster and a lot less traumatic on the patient. Transcranial magnetic stimulation, deep brain stimulation, and bright light therapy are also used. In psychotherapy, what we have found to be effective is cognitive behavioral therapy, behavioral activation treatment, interpersonal therapy, and family and marital therapy, because with these types of disorder, it's very important to have the support of the family or the marriage partner and other people that will be involved in this person's life and possibly be affected by the disorder, but also be the support system for the patient. Suicide risk is very significant in all types of depression, and suicide ranks among the top 10 leading causes of death. Who attempts and who commits suicide? Suicide attempts happen at all ages, but we see it most often in young adults for attempts. But what you may not realize, and what's kind of interesting, is that completed suicides are more common in the elderly. And then in gender differences, men are more likely to actually kill themselves and complete the suicide, where women have more attempts. There's a lot of different theories about this, but one common idea is that women tend to choose less lethal means of hurting themselves, and so they don't always succeed in taking their own life, and men tend to use more lethal means, such as a gun or something that's sure to kill them. Suicide in children, and this can be very alarming. The rates are very low of completed suicides in children, but they are increasing. And suicide in children ages 10 to 14 has increased by 70% since 1981. There's multiple risk factors for children: family support, people that they hang around, violence in video games, television, different things. Other psychosocial factors associated with suicide. One is impulsivity. This is what we see some with children and teenagers. The impulsive, not thinking about, that this is permanent, not thinking past the pain or the hurt that they're feeling right now. Aggression, pessimism, just a negative thinking that, things aren't going to get better. Family psychopathology or instability, genetics, and sociocultural factors. Biological causal factors, again, we've got the genetic component, and then going on in the body, the reduced serotonic activity. We also take into account sociocultural factors. Ethnicity: whites typically have higher rates of suicide than African American, and the rates of suicide vary across culture and religions. A lot of this depends on their beliefs about suicide. Some cultures, it's the ultimate sin. In some religions, that's the unpardonable sin and things. So all of these play a role into the incidence of suicide. Suicidal ambivalence. Some people do not really wish to die, but they're trying to communicate the hurt or the pain that they're in, and they see this as the best way to get people's attention. When this happens, usually their methods are non-lethal, and they arrange their actions so that intervention by others is likely. This may be that they take a handful of pills and call 911, or they slit their wrists and then walk in, where a friend or a roommate is that's going to call 911. This is really hard, though, because we don't ever want to not take a suicide threat or attempt seriously. So it requires a lot of experience and wisdom, but also being able to spend time with that person and see, what is really going on with them and what their goals are. This is a true or false question. Research has clearly proved that those who threaten to take their lives seldom do so. Now, this is a myth. A lot of times people say, well, if that person tells people they want to kill themselves, they don't really, they're just trying to get attention. But let's look at what research has shown. Research has shown that those who threaten to take their lives, or those who take their lives, most often had communicated those feelings sometime in the recent past to someone else. Another thing is suicide notes. Only 15 to 25% of completed suicides leave notes. And having worked with families that have lost someone to suicide, that is a really hard thing, because you're left with a whole lot of questions when there's no note. But then, as you see, the notes can take two different tones. Some notes include statements of love and concern, I love you, please don't blame yourself, please go on and have a good life, and those types of things. But others can be very hostile in their content and blaming and angry, and those can be very hurtful to those left behind. Suicide prevention and intervention. We've got several preventative efforts currently, and I'm sure there's more, but basically treatment of the person's current mental disorders. And if a therapist at any time suspects that a person may be suicidal, they need to ask that person what their intent is. They may get them to sign a no harm agreement, which says that if they feel like they're going to hurt themselves or hurt someone, that they will contact, and they usually list a couple of people. Um, just monitoring those that are on medication or who have had episodes of severe depression. There's crisis intervention, there's suicide hotlines, um, different things. If you ever know that someone has tried to commit suicide, or you walk in and they've tried to hurt themselves, need to immediately call 911. The ambulance will come and take that person to the hospital, where they will be treated, and then they will usually be kept until they can have a psychological evaluation. And then just working with high risk groups, since we know some of the characteristics of those who are more likely to attempt suicide, just a special emphasis on prevention with these groups of people.